Your name, your first name, your last name. Oh. And maybe where you're from or why it brought you here. So we'll start by not the person who's getting her buffet right now, because that's a bit tricky. Maybe we'll start over here with some local friends.
Hello. Yes. It is my Clint Eastwood voice. Chris Lieber, I'm a community pediatrician. I've just been involved with Dr. Dunn in developing a pilot for CMV detection in Calgary, and we've had a lot of fun. And there's a provincial plan, but I don't want to hold my breath when it first starts.
Hi, Fred Kozak, pediatric otolaryngologist, BC Children's Hospital, and part of the early hearing program as a consultant, and working on with a group to do what we're doing here to get it rolling in BC with Dave and many others.
Hi, my name's Mina, and I'm a pharmacist in the infectious diseases clinic here at the Children's Hospital. And thank you, Jess, for inviting me to this talk. I work with Dr. Dunn in helping managing the treatment, prophylaxis of dosing, et cetera, and monitoring of patients on valganciclovir.
Hi, I'm Jen Tam from BC Children's Hospital. I'm a CFID physician, and Estelle, Dave, and Laura Sauve, and ENT, like Dr. Kozak, lots of people are working on developing a more streamlined approach in how to deal with congenital CMV.
Hi, I'm Estelle Morin from BC Children's, Peds ID. I think Jen just kind of said, summarized it for both of us.
Hi, everyone. I'm Cora Constantinescu. I'm a pediatric infectious disease physician in Calgary. I feel very lucky to have Dr. Dunn in our group. And like Dr. Lever, I also feel very hopeful. I think CMV matters, and I'm very grateful and hopeful for CMV Canada, Dr. Dunn, all the people who are working to get a program going in our province.
Thanks.
I'm Carrie Wilkie, and I'm here with my daughter Stacy, and my grandson has CMV.
Hi, I'm Stacy. I'm from Red Deer, and my son has congenital CMV, so that's why I'm here.
Morning, my name's Lindsay Craig. We have a 7-year-old daughter that was born with congenital CMV as well. I'm Lisa Robinson, also a parent. My daughter, who was born with CCMV, is 13.
Nabil Shilazi, I'm a guest of Dr. Larissa Matukas.
There's a group, there's Chris Kern here from Altona, Canada. And we have some colleagues, and they can introduce themselves after. A big thanks to Demille here that Altona has been heavily involved in sponsoring research and the diagnostics fields for congenital CMV and advocating for universal screening. And we see the medical value of this and want to make a bigger impact. Thank you.
Yeah, Chris has said it all. My name is David Smith from Altona.
Good morning, Gabriel Nessali from Altona, Hamburg, based in France, and also supporting the cause of CCMV across Europe and beyond.
Great, thanks. I think we've addressed our technical issues, so I'll hand it back to Dr. Dunn.
Okay, all right. So my time officially starts now, right? Okay, just checking. That little round table didn't count. Okay, so what I'm going to talk about today is universal screening for congenital CMV. There are many reasons why places, people, organizations may want to screen for congenital CMV, but I'm just going to talk about it from what the Ontario rationale background was. Disclosures, the only one I think really relevant today is that I am part of the medical advisory board along with Rupina and Dave for CMV Canada. One day I hope to be able to put on that I'm a co-investigator for a CMV vaccine for young women. And today what I'm going to talk about a little, just to make sure we're all kind of on the same page, is a bit about the epidemiology and the natural history of congenital CMV, to understand its breadth of impact, and also understand its importance as it relates to hearing loss, because that's really where the Ontario screening program originated from, and maybe explains why we've got a lot of ENT sort of support here as well. Talk a little bit about how the program was developed and rolled out in Ontario, as well as share some of the outcomes that we've had, mostly from the first 4 years and some of the big lessons we've learned. And as the person who started this, who is a longtime and well-known in the screening world, said, he goes, it takes a lot to put yourself out on a limb and do something new and different. And so just a bit of an acknowledgement to Pranish Chakraborty for getting that going. So here's my soapbox moment, and that is just for relevance, and maybe a lot of people in this room are already on board, but you know, this was an article that came out in the New York Times, the one on the far right, or left if you're facing the screen, about in 2016 when we started to hear about what was the WHO called a public health of international concern, which was the Zika virus. And if anyone remembers at that time, there was lots of money that went into research for Zika virus. There was warnings on travel bans. And if you're pregnant or thinking about becoming pregnant, you should talk to your doctor before going anywhere where there might be these mosquitoes where you might get Zika, because we're starting to notice that there was a large cohort, mostly in Brazil, of children born with microcephaly or sort of smaller head sizes and developmental delays. And the point being is that while that was very important and worthwhile, we've actually known about something for a really long time that's much more of an actual and real threat to babies that are developing, and that is congenital CMV. And I take it back now, this other article was sort of an opinion by one of the pioneers, Gail Demler-Harris, in the New England Journal of Medicine, and this was written, now you look at it, 33 years ago, and she was commenting about 20 years has been too long. And I'll just read it because I think that some of the important things that she talks about here are really impactful. So in 1971, Weller published a landmark article in the journal, the New England Journal of Medicine, that outlined the scope of the problem in the US and stressed its importance to public health. In the ensuing 20 years, an estimated 800,000 infants in the US have been infected with CMV in utero. More than 50,000 of these infants were born with symptomatic disease. Many have died, and almost all the survivors are severely handicapped by mental retardation, blindness, and deafness. This is language from a long time ago. Many of them will require custodial care for life, creating grief and hardship for their families and collectively costing more than $1.86 billion each year. This was 33 years ago dollars, right? And then talking well that the additional 120,000 congenitally infected infants, although asymptomatic at birth, now have deafness and neurologic impairment. So this was recognized a long time ago, yet as we'll talk about, most people don't actually know much about congenital CMV, and that's, I think, something that everyone agree needs to change. So CMV is a common virus. Sometimes people will talk about it as like it's in the herpes virus of families, so it's kind of like the sneaky stealth cousin of chickenpox or the cold sore virus, HSV. All of us, you know, or most of us generally have some exposure to it. Oftentimes we'll talk about in daycare, so toddlers. And really, it's a mild illness if we even have any symptoms from it at all. And that's for healthy individuals. But there's two populations where we do worry about it quite a bit, and those are individuals who have severe immunosuppression, so thinking about transplants for organs or for their bone marrow. And the other one, which is why we're talking about it here, is fetuses or babies that are still growing in pregnancy. And what we have estimated is that in most countries that are fairly high income or well developed, the range is about 0.6% of infants are born in Canada and similar countries with congenital CMV infection. And it has been established as the leading cause of non-genetic sensorineural hearing loss, and it's the second leading cause of intellectual disability after Down syndrome. So people know about all these things, but yet CMV is not something that people hear about much. So what we do know is that it is a pretty wide spectrum of potential to affect individuals and to their babies. And so only about 10 to 15% of infants with congenital CMV will have what we call symptomatic effects at birth. And approximately half of those infants will develop permanent sequelae, sensorineural hearing loss being one of the most common, some cognitive impairment, effect of the eyes as well, inflammation of the eyes, and cerebral palsy. About 85 to 90% of those children will be born who are asymptomatic, even though they have the infection. And we know that even though they're without any apparent sort of complications or effects at birth, about 13% of those will actually go on to develop hearing loss later. And what we don't really know is how to identify which of those children who have normal hearing at birth and who are like seemingly without any effects will be the ones to go on to develop hearing loss. So it's really hard to also kind of deliver that potential message to a family and say, I don't really know what to tell you. You could be worried about this. There's maybe a 87% chance you don't have to be worried about this, but this is your child, so I know you're going to worry anyway. And we need to do a better job about that. There's more coming out now about understanding balance or vestibular dysfunction as well as children get older, even those who have asymptomatic infection. And there's sort of evolving literature, not at all sort of definitively established, but there seems to be some association with infants who have congenital CMV being more likely than those who don't to have autism spectrum disorder as well. So lots of effects on this. And what I really want to talk about again is then who is likely. And I'm, I think we've got some families in the room, which I think is really important to kind of understand that piece as well. And it's really the common thing. It's at the hospital we hear about, someone has CMV, and maybe some of the nurses who are thinking about having babies are cautious about sort of who they might want to take care of or not. It happens. And really the risk is that the greatest risk is having a young child at home or a toddler. That's where we see the most common sort of textbook scenario of having a mom who gets CMV and then a child is affected during pregnancy. And that is because toddlers, as I think everyone knows here, are drippy in all ways, shapes, and forms. So in terms of like they're peeing, they got the diapers all over the place, their noses are perpetually running, especially once they go to daycare. There's crying, there's like lots of snot and everything else like that. So definitely, and what we tend to do is that needs a lot of cleaning and sort of caretaking. And that's often what we see is when children go to daycare, there's lots of studies to show that there's a high percentage of children at daycare who end up getting CMV, and sometimes it's different strains of CMV. And so the risk is there that we see when you're caring for these children unknowingly, because they're often asymptomatic in healthy individuals, but shedding in all kinds of bodily fluids, that's where it gets picked up. So you'd think if it was that common, everyone should be knowing about this, but that's not certainly what I hear when I meet families for the first time in my clinic. And this was done by the National CMV Foundation, so it's kind of the US counterpart to CMV Canada. And what they did, and what this shows here, I got my laser, yes, as you can see, all these blue bars are sort of the number of children who are sorry, so this is at the bottom, the blue bars is really the number of people who have heard of this diagnosis, condition, whatever it is, most oftentimes infection. And then the orange dot there that we're seeing is actually along the top, the number of children who are affected by this on an annual basis. And so it's important that then we sort of look and screen for these things. And so all those things with a check mark are something that is done as part of regular prenatal or perinatal care to check for these infections. Or there's some counseling and discussion that happens around it, right? So most of the time, if anyone's known someone who's pregnant or been as their own self to their OB or their prenatal care provider, they can't change the cat litter, they can't have any alcohol, and they need to sort of be aware of some of these other things. But really, when we look at what has some of the hugest impact in terms of infants who are affected, and then compare that to actually how many women, pregnant women or women of childbearing age know about it, there's a huge discrepancy. And so something has to be done about that. And now we're going to talk about why that's important and what we see in infants. We're going to talking a little bit about infants who are affected by congenital CMV, and this is Francesca. So she was one of the first infants who was identified by the Ontario screening program. She now in this picture has her cochlear implant in place and is doing very, very well. And so just going to talk a little bit, some of the pictures, just as a heads up, are things that for those of us in medicine are probably familiar from our textbooks, but might be a little bit surprising. So in terms of the classic things we think about with congenital CMV infection, there's things that we have to learn for our pediatric exams, things that we talk about in terms of our infectious disease training. And these are things like the retinitis. So that's the potential for the eyes to be affected by congenital CMV. And so that's why children are recommended to have an eye exam. Hearing, and we're going to talk a little bit more about that, is definitely, as we know, one of the biggest ones. So there's this rash that we see. So this petechial rash, so a lot of little dark spots on an infant is one of the other classic findings. We may see enlarged liver or spleen here in the belly. A child who has microcephaly, I think you can kind of appreciate that their head is probably a bit smaller than the usual proportions we would see in an infant. And then these are from the neuroimaging or sort of any imaging you would do for head ultrasounds and whatnot. You see that there is some impact on the brain. And these are just sort of an example of some of them, but there's calcifications all around here. And then the ventricles there that are actually enlarged. So these are sort of some of the classic things that we see. But that's sometimes the classic things you see don't really capture the whole story. So most of the time, most places in the world, that diagnosis really relies upon clinical suspicion to do testing. So you have somebody that says, okay, I think there's something off. Sometimes that's in pregnancy, sometimes that's at birth. And we say, I think there could be a risk for congenital infection here. Let's check for CMV. And because CMV is so common, and we definitely know that a lot of times infants can easily get it from a loving sibling, from breast milk, from other things after birth. We really have to detect it by 3 weeks of age to say that it is congenital in origin. So congenital meaning that it happens during pregnancy. And the gold standard really is to do is to check their urine, and PCR testing is the gold standard. Serologies really aren't helpful unless they're negative, and it kind of rules out the infection because you can see that the antibodies, mom never had them. So then you know that mom never had the infection, and that's done, but not really that helpful. And then we're going to talk a little bit more about other places that are doing dry blood spot screening, as well as sort of swabbing the saliva. And sometimes when it's not known or there's a question of CMV and it's after that 3-week sort of time frame, you can go back and have the dried blood spot retrospectively tested. It's imperfect, but sometimes it can be really helpful. Yep.
Go back to the other slide here. Now, diagnosis. We focus on loss of hearing, right? Oh, sorry. Diagnosis, usually it's focused on loss of hearing.
Sorry.
Meaning, if you go to the slide before that, you're showing liver problem and other things.
Yep.
But so far, all we hear about, I can speak for myself, it's only about hearing loss. But you have other issues from the slide before that.
Yeah, so I'm just talking about congenital CMV in general. And so this is in the absence of a screening program. These are the many symptoms that might pop up at birth and that might prompt a clinician to do testing. And I'll talk a little bit more about the screening and sort of how that relates to hearing specifically in Ontario. Awesome, thanks. And so this is actually making, the argument is that we know from some Canadian studies here, BC, as well as a sort of a Canadian pediatrics study that was done from some folks in Edmonton, that we know that even though the minority of children are actually asymptomatic, when we see how many are actually being diagnosed on an annual basis, we're knowing that we're not doing a good job of even identifying those who are symptomatic. So there's room to be done to be better at identifying those who have obvious sequelae or complications from congenital CMV and would be eligible for treatment. And there's also room to be done in terms of identifying those who have no manifestations or who are asymptomatic. And that's really where screening comes in. Because really, with even conservative estimates, at this time, we are only estimating to be diagnosing about 10% of the symptomatic infants. So that's a tiny fraction. And part of that is because most infants with congenital CMV are totally healthy appearing at birth and don't have any of these obvious manifestations that might prompt even the most astute clinician to think about testing. So I'm going to shift gears a little bit and talk about why we should care about CMV-related hearing loss, because that's where the origins of the Ontario screening program came from. And what I think is important to understand is really how impactful congenital CMV is as a cause of permanent hearing loss. So this is a really important publication that was put out about 19 years ago in the New England Journal, and it showed that about 1 in 5 or 21% of infants who had deafness at birth, that was due to congenital CMV. And then looking at children who later on developed hearing loss, sometime, but maybe normal hearing at birth, maybe not, but who had hearing loss at 5 years of age, a quarter of those infants, it was due to congenital CMV. And this paper really prompted, I think, a lot of the discussions, at least in Ontario, to say, hey, if we could identify the CMV at birth, and as well as some of the genetic risk factors for hearing loss, we would be able to identify kids, about 60% of those kids who are at risk for hearing loss prelingual, before language develops, and also be able to give an etiology or a reason why about 40% of infants have hearing loss at birth. And that's really meaningful to families. And why hearing matters. So if we look at studies, we see that if you can identify hearing early and intervene early, you can really change the trajectory for children's language development, which has impacts on everything. So for infants who have typically normal cognition, normal developmental capabilities, and have early identification of their hearing loss, their language development kind of meets on par when you're looking at about 3 years old, so 2.5 to 3 year olds, as those who have typical normal hearing and normal cognition. If you identify children who have low cognition and who are identified later, you see that their sort of language development ends up being about half. But what's really striking is to see that those infants who have normal cognition and are identified later end up having language scores or sort of language development that's on par for kids that are identified early and low cognition, potentially introducing like an environmental learning disability without actually doing this, offering this augmentation or intervention for hearing. And it's not only that we see it in toddlerhood, we see that this impact sort of lasts lifelong with the early intervention, and that's really considered to be some diagnosis and intervention, some cases by 6, most of the time, sometimes by 9 months of age, to offer hearing support modification, whether that's a cochlear implant or augmentation with a hearing aid, et cetera. And we see that those language scores, if you have early intervention, continue to progress and to sort of maintain good scoring and sort of learning capabilities. And so this is an ongoing thing. And that's really, as a friend and an audiologist explained to me, because no matter if it's verbal or not, the brain desires language to be developed. And however you're going to introduce that communication, whether it's, again, sign language or sort of verbal spoken communication, that intervention really does matter to do early to sort of have children have their optimal outcomes. And, oh, I think these are a bit older slides, but that's okay. And so what I was going to, talk about is a little bit about the screening then at Newborn Screening Ontario. And we, let me just see here. Yeah. And so what I will say is that it was really realizing that although screening, at the typical screening that started having these little sort of probes put in the ear at birth, which is a typical sort of audiometric screening that happens for infants. That started in Ontario in 2002, and it was fortunate to have it really rolled out and to be available to all infants. What they did notice was that that some of the risk factors for children developing hearing later. So we would ask questions: is there any other infant or child in your family that had hearing loss in their childhood? Did your child have any known infections? Did they have meningitis? Is there any trauma or reason we should think that they might be at risk for later onset hearing loss? And it wasn't really picking up those infants who were most at risk. So what Ontario newborn screening did was they made the decision to add risk factors, which was both the genetics, which I won't talk about today, as well as congenital CMV on that newborn dried blood spot to help identify kids who may be at risk, even if their hearing is normal at birth, to be identified early and have that intervention to optimize their long-term outcomes. And so people will often know that the newborn screening that happens at birth is often just a dry blood spot. So there's a little heel poke that happens. It gets dotted on a bunch of cards. And most of what that is done in Ontario, there's 30 conditions sort of from different categories of metabolic diseases, endocrine diseases, sickle cell disease. We screen for severe combined immunodeficiency and others. There's also screening that is done in terms of looking at the oxygen for an infant at birth, so looking for congenital heart disease that might be important. And there's biliary atresia or liver dysfunction program that also exists at Newborn Screening Ontario, as well as this permanent hearing risk factor screening. And so that's where the introduction came to add risk factors to that dried blood spot so that infants could be screened and followed closely for any hearing loss development. And it was at that point, things have changed over the last 6 years, but at that point it was a joining of 2 separate ministries, which was a no small feat to kind of get 2 separate governmental bodies to come together and sort of create a united program. And what would happen was that the hearing screening, which is a formally consented program in Ontario, would then, if you had your child do their regular hearing screen with the little probes in their ears, they would also be asked to say, would you like to test for risk factors for hearing loss? And most parents in the newborn period maybe aren't always remembering, but we found that most of them did say yes to doing that. And that would then transmit a consent over to have the risk factors, so the genetic and the congenital CMV testing done on their newborn dried blood spot, and then release sort of these results to families. But it does get a little bit complex. So in Ontario, I'm not there anymore. Like many Canadian provinces, is large. Definitely the concentration of the population is in the southern half of the province, there as we can see. And for Newborn Screening Ontario, as well as for the infectious disease tertiary care centers, there are really sort of 6 referral sites where there is a positive screen by Newborn Screening Ontario that gets referred to one of these academic pediatric centers. And those are in Ontario, Kingston, Toronto, Hamilton, and London, and then many from the Northwest will end up going to Winnipeg just because it's closer. And then within the Ontario hearing screening program, all of these same areas did have hearing lead agencies or screening programs where the sort of full diagnostic assessments could be done for babies. And there was also an additional 6 of them that were around the province as well. So these are the different centers that have to coordinate to offer care for infants identified through the screen. And what we trying to get done for an infant who has been identified as having a positive screen on their newborn red blood spot is the standard workup that is done by every recommended international guideline. And that is, oh, I think this is definitely the wrong slide deck. Okay, is that we have the urine PCR that's done, so that confirms the infection that is actually present. We thought it would be just a check mark. Turns out it was more interesting than that. We have then a physical exam that is done, and it's a full assessment both of measurements to see if there are any neurologic concerns on it. There's standard blood work that is done to look for low platelets, as we saw with one of those earlier infants that had an effective quite low platelets, head ultrasound to look for changes in the brain, eye exam to look for any evidence of CMV in the eye, and then a diagnostic audiology. So not just the screen, but a full audiologic assessment. And the goal initially was to really have that done by 4 weeks of age. And the reason to have that done by 4 weeks of age is because when the program rolled out, the recommendation was for any infant that did need treatment with antiviral valganciclovir, that should really be initiated by 30 days of age. So really kind of put the time cooker, I would say, on a lot of the program to get this done. And one of the things that we did was at the outset was we engaged pediatricians from across the province who are willing, community pediatricians who've definitely, along with the nurse practitioners, been the backbone of this program, to agree that they would be interested and able to see these screening referrals, be able to see them in a timely manner, so within a week or so after they were identified and the referral was made to their office, and be able to help undertake these investigations so that we could make the decision if they needed to be seen by infectious diseases and if they needed further sort of intervention and treatment with the antiviral. And that, you know, that is something we'll chat about a little bit later. But I think one of the important things is that it meant, number one, not every single screen positive infant was being seen in the infectious disease clinic, which could, some clinics may had some capability to do it, others probably didn't, but also meant that there didn't have to be an elevated, we thought, level of like, you have to travel really far if you're from anywhere in the province to go down and see this specialist for your baby that appears completely and entirely well. And so there's a lot that kind of went into doing that. And the way the pathway works in Ontario is our nurse practitioner, every week we get the number of screens that are identified positive. She, and I say because it's all female in Ontario right now, and so the 3 nurse practitioners or 1 nurse, triggers a medical referral to the community pediatrician that has been rostered with our program and agreed to see these infants. They, oh yeah, wrong slide deck. We'll do the initial CMV assessment that I showed on that slide before. If there is concern that they do have symptoms of the infection, so all those things that could be there, whether there's size, whether there's abnormalities on their head ultrasound, anything else, then a referral or conversation is had with pediatric infectious diseases. Are they infants that, because of their symptoms, would necessarily be indicated to start treatment or not? And then they're continue to be followed in some cases on treatment by the Pediatric Infectious Disease Service, oftentimes going back to be followed by their community pediatrician. And certainly if there's no symptoms identified, an entirely normal exam, which again is the majority of the infants, about 85%, they will just be followed by the community pediatrician. At the same time that the newborn dry blood spot screening is reported to the nurse practitioners at the different ID sort of centers, there's also a report that goes over to the infant hearing program, and they arrange to have a diagnostic audiology assessment. So again, this isn't the quick check in the ears. It's sometimes like a 2-hour assessment that has to happen with your baby, and they have to be sleeping and in this sort of soundproof room and everything. And it really requires a very specialized and highly trained pediatric audiologist to be able to interpret these. If there is hearing loss present, that gets factored into consideration of symptoms and reported back to the pediatrician or the pediatric infectious disease clinic. And then if there is any concern about hearing loss, obviously that will get managed by the audiologist/ENT, depending upon the degree for it. And if there's none, they just continue to be followed in the surveillance program. And what that looks like in Ontario right now is very similar for both. The only difference is that if a child is identified as having symptomatic CMV infection, they have an additional 2 visits in the first year of life because we know they're at higher risk for going on to develop hearing loss. But otherwise, it's the first year as the toddlers 3 and 5 years of age for the hearing surveillance piece. And then we ask the pediatricians to see them 3 times a year for the first 2 years of life when lots of development is happening. And there's an opportunity then to make appropriate referrals, support as they might need it for physio, for OT. Hearing is usually already encompassed, but anything else that can be done. So that's kind of where we are in terms of the background. Now what I'm going to do, and realizing I think we got a bit of a late start, but I know where we're at, is just talk a little bit about what we learned. And we were really excited to be able to finally in January share the outcomes of the first 4 year of our screening program. And it was a lot that was able to come together, and we hope that's going to be useful for other jurisdictions. And so in the first 4 years of the program, there was 565, almost 66,000 babies who were born in Ontario. 97% of those did have some screening for congenital CMV. And what we found was that 689, or about 0.1 in 800, 0.125, were positive for congenital CMV. Of those, they went on to have their initial diagnostic evaluation, which I shared about in the previous slides a few slides ago, and it talked about all the urine and the rest of the workup. And what we noticed that was quite a big surprise was 56 infants who had their urine tested actually had a negative urine, and that was something I'll talk about in a second, but a bit of a surprise for us. 600 had a positive urine, and then for various reasons, about 33 didn't have it done. I do note that we don't exactly know what the false negative or the missed number of children are, but we did have information reported back that there were 19 infants who were reported to have congenital CMV that were screened negative and on the initial test. Of those that we were able to solidly confirm that they had congenital CMV infection, 607, 601 of them completed their workup. And we found pretty similar to what's been reported in the literature that about 16% had some form of symptomatic infection from that. And of those, about 80% or 77 of the 96 with symptomatic disease were offered antiviral treatment, and 80% of those actually started on treatment. And I think we're going to hear a little bit more about that discussion from the Hamilton folks soon. So we did have a range of findings, and one of the things that was most, I think, striking was that there was some abnormality, and whether that was relevant or not, but there was some abnormality on the head ultrasound. How sort of impactful related to CMV or not has been the subject of many, many discussions, but we just reported it, and that was in about 70% of the infants who had some sort of symptomatic infection. About a third of our babies who had confirmed CMV infection had hearing loss. So that's really what we're setting out to do. And a lot more has to be done to find out which of those infants who had normal hearing at birth are then going to go on and develop hearing loss later to know how we could have intervened with them. This is sort of a summary of the hearing loss, which we found is bilateral, unilateral, sort of various range from anything from minimal all the way to profound, for which these children would be eligible for cochlear implants. So just coming through to some of the lessons that we learned from this first 4 years. As you will recall, we had we had the initial, until the pandemic hit and disrupted everything, we had consent-based approach, and that was about 99% of families consented to having the screening done. What we found is when we waived the consent, we were able to streamline the process, and it was much of the ID docs loved that they were able to get kids in a lot sooner, make a diagnosis and make treatment decisions without sort of having that pressure of being sort of too late. We did return to consent in March last year. A lot of improvements have been made. So we're not in the same situation we were before, but there's still room to do a little bit better because of this consented process. So we get about 90% of infants where we have consent received by 2 weeks of age. The urines. So happy to talk about this, but maybe we'll just sort of go over it for the interest of time with where we're at. But we had initially about 56 babies who had screened negative in our first 4 years who had negative urine testing done. And we initially kind of thought this was a one-off. We investigated on a case by case, a bunch of different ways to look at it, and then said, this is really a systematic problem. We heard about it in Minnesota, we heard about it in Saskatchewan. And so a quality initiative was introduced in 2003. And the outcome of that was really if we were able to send every urine and have it be done on the commercial test, we found out there was really good concordance with that commercial test that actually is Altona's. So shout out to our sponsors here. And that was really reliable, and we're now able to discharge those infants from the screening program if they have a negative urine. The ophthalmology clinics, I will just say that we had some feedback from the ophthalmologists, very crowded clinics, very long waiting lists and everything else. And we really said, hey, these are infants that are seeing, most of them are fine. We're putting infants through this difficult exam. It's unpleasant. They have to travel from far, and we're not finding a lot of disease for them. So can we relook at our information and sort of see how we can prioritize these referrals? And we hope to be able to share this in a publication soon, but essentially we looked back on 2.5 years of data and found that of almost 350 infants who had a positive screen for congenital CMV, only 2 of them had any findings related to CMV. And so both of those kids were quite obviously symptomatic at birth, and we were able to then, now we've made the change that any child who has any finding on their initial workup still gets seen and referred to ophthalmology, but a lot of those others who are asymptomatic don't. Symptomatology, I think we're going to hear about a little bit of the challenges of this from Hamilton as well, but really wanting to say that when you are identifying children through a screening program, these are kids who most of the time are very well and healthy appearing, and you're going to find lots of unexpected and maybe non-specific findings, and what to do with those is really, really a challenge. It's easy when it's very dramatic. It's easy when it's completely normal, but there's a lot of gray that has really been the subject of endless, I would say, discussions among our ID working group. And right now, what we're trying to understand, because of the biggest impact, is really with the head ultrasound findings. Officially, if there is neurologic or central nervous system involvement, that is an indication to treat. But if you have a non-specific finding, really what does that mean? And is the head ultrasound giving you all the information you need? So we are now offering any infant with an slightly abnormal finding on their head ultrasound and MRI, and looking back at 12 months of that data. And the last sort of thing I'll touch on here before wrapping up is just that, as you will remember, I talked about it being about 1 in 200 or 0.56% of infants who we think have congenital CMV infection in countries like Canada. In Ontario, we're finding that number to be quite a bit lower. So why is that? We did a lot of this during the pandemic. Ontario was closed for probably a lot longer than other places. That certainly has been demonstrated in different areas of the world to impact the rate of congenital CMV. There's lots of discussion about using the dry blood spot as a modality. We know it's not perfect, but the other question is, could there be a lower prevalence overall for congenital CMV in Ontario? And I will say, prior to the pandemic, we did have higher rates, but about 0.17%, which is about 1 in 580 infants screened positive for it. And we're going to look back and see where we're now kind of getting out of this pandemic phase. But I think this is something that still remains unanswered, and we're really trying to look at it with many people here involved on sort of comparing the dried saliva screening process to that. So in summary, I just want to say that in Ontario, it has been a complicated condition to screen for. It has been very time intensive. It's been full of challenges, some of which we expected and some of which we did not. But it is absolutely providing a more comprehensive understanding of congenital CMV infection. It has, I won't say sort of across all fronts, but I think within those involved and within our pediatric community, increased awareness of congenital CMV. There's still a lot of work that has to be done there. And to date, we're almost at 900 babies as of talking to folks at the program yesterday who have confirmed congenital CMV infection identified through this program, most of whom would otherwise go unrecognized because we know that either they have no obvious symptoms at birth or that we are imperfect as clinicians at recognizing this. And I would say it's definitely had an overall very positive impact. The saying goes, it takes a village to raise a child, it takes a province to screen one. So this has been a very huge effort and multidisciplinary across the province, and lots of effort, lots to still learn and perfect. But I think we've sort of really sort of laid the way to see a new change in terms of screening for congenital CMV. And I'm going to say I'm actually within my 45 minutes. I feel really good.
Great, thanks so much, Dr. Dunn. So we'll, without further ado, move on to our next speaker, Dr. Purewal, who will tell us about developments in Saskatchewan. And my thought was we'll have, because there's going to be some common themes, I think, around that we'll have some of the questions after both of these talks. Great, thanks.
Perfect. Thanks so much, Dave. I want to thank CMV Canada. I want to thank Dr. Dunn and Dave for inviting me to speak about our experiences in Saskatchewan. Ontario has done a lot of the forefront work for us, so we were kind of lucky to have such great support. And yeah, so I was asked to, my slides. Not sure if I'm supposed to. Oh, there we go. Okay. Perfect. So yeah, so I was asked to speak about our experience. So what I named this talk was the Universal CMV Screening Saskatchewan Edition. Our screening program started a few years behind Ontario. And so like I mentioned, we had a lot of support from them. And so today I'll discuss kind of from inception what hurdles we faced after the inception of our program, and kind of currently facing, and how we've kind of worked through it. And so I guess without further ado, my conflict of interests are listed there. I am also on a medical advisory board for CMV Canada as well, but everything else unrelated to today's talk. So the objectives of my talk, I will walk through kind of the workflow, quite similar to what Ontario has done, because we did kind of steal some of that information from them, and then kind of how we've worked through it and made some changes already within the first few years of our program implementation. And then I'll talk about some of the key challenges, and that's really the focus of today's talk for me, is to discuss some of the issues that we're facing or have faced and how we fix them or are in the process of fixing them. I'll touch on some of the numbers in our screening process, but really won't emphasize on those. And then the latter part of my talk will include some of the insights and lessons learned for us to help guide other centers who are looking to initiate a program. All right, so when we first started a similar process, so we had the newborn screen kind of positive. When the screen went positive, our provincial lab, so that's the Roy Romano Provincial Lab in Regina, and the newborn staff there would inform the Genetic Resource Center. So that's where our avenue was. So we did not have initial nurse practitioner part of our protocol, but we had our genetic resource team who was receiving all the other screen positives on the newborn screen to also get a positive result for CMV in any of these infants that went positive in that less than 21 days. So they were initiating the process and actually reaching out to family physicians that would be involved and kind of asking for permission for their name to be put on the requisition, appreciating that Saskatchewan is a much smaller province than Ontario, so a little bit easier to contact and obtain this information. If we were unable to have that initial contact with the family physician, the requisition could be placed under one of our microbiologists. So that was initiated by the Genetic Resource Center. They were also the ones contacting family and having discussions around the positive screen, explaining congenital CMV, and as many of the parents that are in the room today can appreciate that first 21 days or actually first few weeks of postpartum life is really challenging already to begin with. And so getting a diagnosis like this and the whirlwind of information that you get can be challenging. And so we were trying to upfront provide that information. After that, the GRC contact would provide the family with pre-filled a urine requisition, and then they're asked to go to the lab and obtain that urine sample, which is our confirmatory sample. And then alongside that, GRC also, which is the Genetic Resource Center, staff would contact the newborn hearing program as well. So we also did a simultaneous informatory at that point. And then once the result went positive, so we have a confirmed CMV result from the urine PCR, the provincial lab was then including the pediatric infectious disease specialists to now be involved with risk stratifications in the initial screening process. And then we would carry on from doing more of the clinical care and follow-ups and risk stratification for these patients, whether they needed treatment or not. So as you saw from the Ontario program, this was a little bit different approach in terms of that we were involved very late, me being we as in the pediatric infectious disease physicians, and that became quite challenging because there was a delay in the process, and I'll go through that in the next couple of slides. So how we've changed the protocol is that now within the 5 to 7 days of the screen, so the initial dried blood spot screen going positive, our pediatric infectious disease team is involved and notified early on. And so this is before the confirmation occurs. And then we are actually, I shouldn't take the credit for this because my clinical nurse coordinator, who's actually on the line today, Melanie Vanilla, is the one that's involved in actually reaching out to the family, obtaining the urine sample, explaining CMV. And I think coming from a clinical nurse approach was a better idea. And then also having that initial rapport with the family. And not only that, having the questions come back to the pediatric infectious disease physicians if there are any more detailed questions or answers that are required. So that's the process that we kind of changed to. And so the urine specimen collection and the details of all of that are now arranged by the PEDS-ID group. So we're involved earlier. So challenges, like any program or anything that starts new, there's always challenges. So some of the challenges, and you can see the issues there in red, and then how we fix them or we are in the process of fixing them. So one issue that we had early on was a delay in obtaining urine samples. And this has been actually fixed with our improvement with being notified early on. So because our clinical coordinator is involved early on, we're able to build that rapport with families. We're able to guide them in terms of where to go to get the urine collected, because that's an issue. And similar to many provinces, Saskatchewan has people travel all over the province to get things done and also don't have sometimes lab access close to them. So arranging transportation has been one of the other things that we've done. So that's been helpful. And then also building that rapport, like I mentioned, and just connecting sooner. Next, we had issues with which I think Jess talked about as well, the false negatives due to low volume, or at least the false negatives on the urine. So one of the things that we were encountering was low volume samples being submitted. And I think this is something that oftentimes, even from like a clinical standpoint, we don't look at it. But definitely from a microbiology standpoint or the lab perspective, volume and sample size is really important. And so in informing the family, the required sample size has helped us mitigate some of these issues. And so what was happening here was that we had a false negative, and the way we figured out was due to low volume was obviously the sample that was submitted was less than a certain amount. And then when we reran these samples with a higher volume, i.e. the 20 ml or at least 10 mLs volume of urine, those samples went positive. And so now we have protocol adjustments made. So we suggest a volume of urine to be 20 mLs, and then 10 mLs is required. So preferred was the 20 mLs. 3.5 to 10 mLs is an acceptable amount, but we'll have a comment there that there could be a false negative. And then under that 3.5 ml, they'll analyze it. If it does go positive in the lab, then it's reported as positive. Otherwise, it's canceled and suggested to repeat the sample. So that's helped us kind of navigate that. And also our nurse now is able to provide this information to family, which has helped with the initial samples being adequate. On to other issues that we had. So the long turnaround times for a newborn screen, and this is something that we're still in progress with fixing. And so not sure if like all the conditions that are on the newborn screen are as time sensitive as CMV. And like Jess talked about, that 21-day or within the first 4 weeks, we do need to make a decision as to if we're going to treat these patients or not. And not only that, have to go through the array of tests, including head ultrasounds, imaging, and et cetera. And so we're trying to get our labs to work with the newborn screening staff to see if we can change that turnaround time and not have that delay. So this is still a work in progress for us. Another issue is the delay in risk stratification, and this was mainly related to a delay in workup. So this could be, I guess, a compilation of steps where it was either a lack of follow-up or unable to reach the family. And then not only that, once we've been able to contact the family, just a delay in obtaining the urine samples, like we mentioned, and then the follow-up workup. And I think for our province, the initial thing was to really work with all the stakeholders that would be involved, because I think information is key here and communication is key. So for those and implementing a program, I think early on we had radiology involved to discuss kind of the time-sensitive approach of these head ultrasounds, and then and really emphasize the urgency of them, and also to get more centers in your province involved to perform head ultrasounds. And that's helped us actually over the last year here, because we only had Saskatoon and Regina that were providing those services. And so families were having to travel. Again, there's a delay there because they can't just get up. Everybody knows with a newborn, that's not an easy ask. And so, and other children. And so to mitigate some of the delay there, we've had other centers and other imaging larger centers and smaller centers agree to performing the head ultrasounds, and also being able to send them out for a report. One of the other challenges, and I think it's still an ongoing challenge for us being a province that only has the two largest cities and a lot of travel involved in between them, is the limited audiology services, but again, remembering that this is time sensitive. So early on in our protocol, we did have audiology in the newborn screening hearing program involved fairly, actually earlier even than pediatric infectious disease was involved, because we needed that information to help risk stratify. So even when we came up with the initial protocol, they were simultaneously informed as the family doctors were informed for the protocols to start to initiate the process. And so despite that, we've still had limited audiology services. We also have an array of other congenital infections that are peaking, so congenital syphilis, which has taken up some of our audiology services as well. And so I think things that we've worked at is to discuss kind of with multiple sites in our province to see who can perform these and try to rush these and reduce that travel time for families. So we're still working on some of those. Another issue, which is probably a bit more unique to Saskatchewan, is that we have a city called Lloydminster that sits on the border. So half of Lloydminster is in Alberta and half is in Saskatchewan. So as you can imagine, we're already trying to implement a province-wide screening program, and then all of a sudden now you have to deal with a border province, which makes it difficult when you don't have a similar screening program in both those provinces to kind of divide up the patients or have an algorithm or protocol. So there's been multiple calls from my colleagues out in Edmonton to be like, do you know about this patient? Is this on your guys' side or our side? And so some of the issues that we've had are confusion with processing these specimens, and had to work through our protocol to see how do we get this back to our provincial lab, which is in Regina, and not over to Edmonton, where then we don't hear about them and then they can get missed. And that's challenging, as you can see, with a 21-day turnaround. And so the way that we've tried to mitigate this is that if the family is residing on the Saskatchewan side of Lloydminster, then the hearing test will be done by the Saskatchewan team. If it's in Alberta, then it will be done by the contact in Edmonton. But the urine must be collected and submitted at the hospital. So if it's submitted and collected at the Lloydminster Hospital and not a peripheral lab, then those results will reach our provincial lab and not Edmonton, so we don't have that confusion. So that was something that we had to work on. So if anybody else has kind of similar areas, or in general, if you're in a province where there's going to be multiple labs performing the urine PCRs, I think that's some of the discussions to be had early on. Like I talked about, the loss to follow-up. So some of the concerns that we've had is to obtain the urine sample collected, and whether that's because we have families that don't have a contact number or don't actually have a lab close by to them. And so we've had some challenges with that. Our process here has been that the provincial lab has helped with that. So they make the calls to the family on day 1, 2, 3, following that newborn screen result. And then another one kind of at that 1 week mark. If no samples received by the day 5 mark, that's kind of alarming us that we're not, there's nothing in the works here. And so we need to remind to submit that sample. And so then recalls are set at week 2 and 3 as well, if that initial contact loss is not received. And then eventually, unfortunately, we would have to classify them as lost to follow up when we're doing our statistical analysis. Similar issues that we faced after starting treatment is the inability to obtain any follow-up blood work or concerns with side effects. It's actually been much better since we've kind of known about the screen earlier, because we can then build that rapport with families and also support them if there's any hurdles in obtaining lab work. So transportation can be provided. We can arrange for the labs to be done at the same time. So we've done kind of our initial assessments in the Jim Pattison Children's Hospital in Saskatoon on the same day. So they'll get audiology in the morning, the labs kind of few hours after that, and then have the pediatric infectious disease team see them in the afternoon. So it works for our province because we have smaller numbers, and so all of us can work through to see these patients. So that's what we have been doing locally, and that's helped. And then most of the follow-up appointments, especially for if they have to travel, if families have to travel more than 2 to 3 hours to come to us, the follow-up appointments we've been doing over the phone with weight checks done locally at their center. So that's how we've kind of worked through some of these challenges. Our local numbers, so obviously our program has not been in place as long as Ontario's, but since 2022 till now, we've screened over 43,000 infants. And the initial positives on that was 94. We did have our false positives rate as well. That showed that we had 3 infants there. And then some with insufficient urine, but that was the ones that we were unable to, even after multiple attempts, get a good volume on. And then the loss to follow-up was 14 infants. So out of that, our number of confirmed positives was 75, 91 if you kind of remove some of the insufficient urine and the false positives. So as Dr. Dunn here mentioned, their initial incidence was actually 0.17, which is interesting because that's where we're sitting at this time compared to Ontario's incident now. And whether that's because we actually started, or most of our program has actually been at the tail end of the pandemic, and whether that factored in more. We're also a smaller province. So I think I don't know if to think back because we had differences between the Alberta and Saskatchewan side in terms of when pandemic protocols were and how they were lifted. But I think things did ease up quicker in Saskatchewan. So maybe that had something to do with our slightly higher incidence over the last few years. All right, so what did we learn over the last few years? So I think for those that are trying to initiate a program, I would probably emphasize number one, the critical step is engage everyone that you think you need to be involved in the planning of this process. So if all the stakeholders are involved in the development of the process, it makes it much easier. We did have a similar process and then still encountered some hurdles because we thought from a pediatric infectious disease standpoint, we wouldn't need to know about everybody until they had a confirmed urine, but then we saw the challenges with that as well. And so we're able to change our protocol based on that, but definitely engage everyone that you think and early on. Understanding specimen flow, I think, within your jurisdiction is super helpful. So knowing who is going to be performing the urine CMV PCR, is it going to be multiple labs like we talked about, even with the false positivity rates, using different assays is a problem. And so trying to kind of centralize that would be a great approach. And I think that we've seen that with Ontario as well. Furthermore, just discussing the turnaround times with a newborn screen. So I think because this is a very time-sensitive condition and we need information sooner and earlier on, I think it's important to streamline that as well. So we have some of that information, because if it takes about a week to get the result, you are limiting yourself to about 2 weeks to get everything else and then risk stratify and start treatment. And that can be challenging, especially if you can't get the workup done quick. I think establishing the protocols for urine submission, I think that now has been more streamlined for us because we have that minimum volume, and we're also able to inform the parents initially, right? Because they will not be aware of that volume and may think, even a drop would help us, but we need to make sure to inform that 20 ml is the preferred volume. And then going from there. So I think that is important to discuss when you're establishing your protocols. Support staff, ensure that they're hired, and this is discussed in advance, who's going to do the initial visits, who will do the follow-ups. I think for us, being a smaller province, it's been nice that the pediatric infectious disease, myself and my colleagues are able to see all of these patients. But as our population grows, I think we will also need additional support staff. And we're kind of working actually already at kind of creating more opportunity for nurse practitioners to be involved, because I think that's a great avenue. So just like you saw in the Ontario program. But definitely having that involvement with the pediatric infectious disease physicians early on in the process is helpful, as you can see, from a lot of reasons. And really just supporting the families as well, right? Because we want to have that information out. It's scary. It's scary when you get the diagnosis and then you have to tell them either over the phone or in person, that now you have to kind of worry about one more thing, not all the other things that you have to worry about. But you also have to worry about the hearing loss that's actually progressive. And this is not a one-day stress if this is a negative test, or, you know, you have to worry if they can't hear in a few years, that type of thing. And so I think as being a parent, I think it's already scary having children and all the things that you know. And then now you have to add on this condition, right? And something that's not really talked about in pregnancy, like Dr. Dunn mentioned. You know, we talk about all the other conditions that can affect the fetus or the infant, the baby, and that I think education is really key, and we need to spread that. And I think CMV Canada has done a fantastic job actually supporting our families, but not only that, supporting clinicians. We've had a lot of pamphlets and information that's been provided by CMV Canada, and so use your resources. Reach out to Kayla. She's been really helpful. In terms of the last point, education again. So this is not only for families, but also for our colleagues. So I've had multiple times where a family doctor has reached out and said, I'm not really sure. I think I know how this affects the baby, and I don't know the long-term effects of this, and I don't feel comfortable having this discussion with the family. And so would you be able to provide us with that support? So we've done some grand rounds that Kayla has come down to Saskatchewan as well, and done some education around CMV in general and how it affects. So I think today's talk is also good for information spread and getting everybody in the room familiar with this condition and what it can do. And that goes for even early on in pregnancy. So talking to the obs-gynae, nurses, pediatricians, just about the process and what the screening really is about. I would like to thank our amazing teams. We have a wonderful group of microbiologists at the provincial lab. We've had a lot of help from our molecular genetics team as well, Nick. And then our newborn hearing screen coordinator as well. And then I mentioned Melanie Bonilla, who's our nurse clinical coordinator, who does a fantastic job for us. We have a lot of support from ENT as well. Dr. Mick has been involved actually even prior to myself in this and in the inception of this program. Unfortunately, he was in the OR today, so couldn't be part of the talk, but has helped a lot and has also helped me a lot during the analysis of our program. So done a great job there. And then GRC as well. And then definitely shout out to my PEDS-ID colleagues in Saskatchewan who helped me with follow-ups. Thanks so much.
Great, excellent. Thanks so much for that talk. It's been really great to hear about the developments and how many children have been identified and now are having access to services, and including hearing screen and the other services you guys have been providing in your provinces. I'll maybe take moderator's privilege and start with a question of my own first, and then I don't know if we have a question, maybe we'll go next to the chat. There's a few jurisdictions represented here, and some of us are in the process of putting together budgets and thinking about your programs and what if budget wasn't an issue, which obviously now is not the case, but budget was not an issue, what would you maybe want to have in there? Or what have you already added? I heard discussion about a number of things, including nurse practitioners and other parts of the program, people in the program, but anything you'd want to kind of highlight that you might say would be important that you didn't know about that you then learned was important to add?
Yeah, I mean, so I don't know if it was didn't know, but I think we are continuing to, for Ontario, continuing to realize the value and the need and, you know, of having basically a point person, which for us is mostly the nurse or the nurse practitioner. And I think that kind of, to me, was underscored by what we heard from Saskatchewan about if you're going to do this, it's totally worthwhile, but I think it needs to be done so it can succeed. And can be a complex condition because it requires a sort of a multi-pronged workup. And we're in a place where sometimes it's not all densely populated and things are spread out. And having the nurse practitioner who both have the skill set to talk to families, to offer them like some understanding and, you know, done training about how to deliver a new positive screening result. And that I think that in handling the range of potential responses, and then also to sort of be that contact point that the family can come back to in a time of initial uncertainty is incredibly important. And I don't think, I think that in Ontario, it seems to be working well to have the community pediatrician involvement, and maybe that's a different because of just differences in the provinces and numbers and setup, but I think that has also been excellent. So that personnel part is what I would absolutely say is probably way more worth way more than we pay for it, but you have to have it.
Yeah, I agree. I would echo that. I think having probably a multidisciplinary team, whether like those are clinics arranged with nurse practitioners, infectious disease, ENT, would be kind of another thing. Because I know with families that they have to go to a separate appointment, kind of flip-flopping through that. It's already a stressful environment. So that would be somewhere, again, just adding personnel and creating that team of clinics.
Thanks. We'll go to the webinar chat.
So there's one question online. Let me just find it. Actually, there's a second one now as well. So the first one is, I am wondering if there is currently a rise in the prevalence of congenital CMV in Canada, which may explain the focus on this topic. Since the initial detection in 1971, I'm curious to understand why it is gaining attention now. Also, for screening in Ontario, carrying out DBS and saliva screening is if DBS is not totally reliable.
So the first one, you know, I think it depends. I think it depends who you ask if it's getting attention now. I think there's been a lot of people that have been screaming for a while for this. And I think there's part of it is that in 2015, there was treatment that was, I'll say, more accessible and more doable for families as an oral option for those that were severely infected. And that, I think, in a lot of ways has complicated the screening program that it was designed to do for the hearing perspective, because it adds another layer of time crunch and sort of resource need. You know, I think there's been a lot of people that have been, I think it's been around for a long time, and I think people are finally recognizing it, and I think there's more that's voices are getting louder, like many things that are getting louder, and there's more that can be done at this point. So I think that's why it's coming to the forefront. You know, the question, if I hear about, I don't know that I would use the term that DBS is unreliable. I think, you know, I would actually not, I find it hard pressed to ask the 600 families who we identified in the first 4 years if they think that it was not so reliable. And I just say that because it's imperfect. And we know, although we don't have all the data yet back with the saliva bit, that is also imperfect. And it's probably more prone to picking up potentially postnatal infections and sort of maybe a higher rate of what ends up being false positives. And that's well established in the literature. So I think the other thing that you have to be very practical about is if you're going to introduce any screening program or the operational considerations. And in Ontario, because the screening for severe combined immunodeficiency was introduced, which was the first step in extracting the DNA from the dry blood spot, that made it incrementally easier to then do DNA testing for some other conditions such as, well, one is spinal muscular atrophy, but as well as for the genetic and the CMV risk factor screening. So that's why it was, I think, from a practical consideration, doable. But no one's done it before, and we're learning. That's also where we're at, I think.
Just see if there's anybody in the room who wants to ask a question before I go back online.
Thank you very much. It's really exciting to celebrate the success of some of the provinces that did successfully manage to have this kind of program, and to also appreciate the unbelievable amount of work and coordination that it took. We're seeing more differences in provinces and territories in terms of what kind of screening programs or immunization programs they have. I see Jess knows where I'm going with this. What kind of advice do you have for those provinces that don't yet have a program in terms of how to advocate to their governments, or to where we advocate for this kind of approach? And I think you're well situated because you have a very strong patient advocacy group. So maybe how do we advocate for this in other parts of Canada?
So this was actually a little bit before my time in the program, but I know that our ENT specialists had a huge hand in advocating for the program. And so even now, we've had a few patients that have been picked up with hearing loss or profound hearing loss at a much later age, and then had gone back and tested their newborn dried blood spot for the newborn CMV screening process. And when that dried blood spot came back positive, and you're dealing with a 4 or 5-year-old who has hearing loss, it's quite impactful. And to bring that forward to kind of stakeholders, ministry, looking at kind of the costs of not implementing treatment early, and seeing kind of the benefits that you can see with treatment of being on valganciclovir for that 6-month period, and what the hearing results have been. I think that was one of the pushes that helped Saskatchewan, at least, kind of make that move forward, is looking at, because hearing loss is not a minor disability, right? And so I think it's important to probably bring this from multiple physicians, multiple areas that are involved, disciplines of medicine, and the ones that are seeing and doing the cochlear implants. I think that was quite impactful for our ministry to be more involved and worried about things. So that's how our approach was.
Maybe just a quick follow-up. Yeah.
Well, I just wonder if Kayla wants to speak a bit to the advocacy piece, because I know, obviously.
I'm going to ask Kayla to answer the question for Cora, but anyway.
Thank you. So it's been really interesting because every provincial health authority is so different. We've had a really different approach in every region. We were fortunate in Ontario that there was a group of kind of innovative thinking people within newborn screening and audiology and infectious disease. In other regions, we've just tried to make a lot of noise. In Manitoba, we went a more political route, did a bill, went through legislation, and that was quite effective. So I think just getting in touch with all the potential stakeholders, whether it's, ENTs, audiology, Peds ID, community pediatricians, and then also connecting with families. And CMV Canada is always there to support. We have efforts underway in just about every province that doesn't currently have screening, but we're always looking to connect with other people, both from healthcare and on the family side. And we're willing to help kind of make some noise, whether it's getting media attention, reaching out to MLAs, just kind of getting anyone who might be in that decision-making position to support. Yeah, I don't know if that's helpful, but yeah, thank you.
Yeah, and just to speak to that, I think a lot of people don't realize in Canada right now, the majority of children born are either in a province that's implemented or is committed to implementing universal CMV screening. So there's already a lot of that advocacy has already paid off, but obviously there's still ways to go. Oh, Des.
So I agree with everything that's been said. And obviously, I am a supporter of screening. One of the things that Pranesh always talked about at the beginning is that there are harms of screening. There are more benefits than harms, right? But like when you think about anybody who's talked to a family on the phone to tell them that their perfect baby has a virus infection knows that that produces anxiety. It's hard to get places. Where do you get an ultrasound? All of which to say that I think Jess, I'm just a hanger-on, has spent a lot of time trying to figure out how to maximize benefits and minimize harms in the Ontario context. And I think context really depends. Like so many of our provinces are so many, like I think Ontario, there's a giant difference between downtown Toronto and Sioux Lookout. And those are magnified across the country. And so when you think about all the pieces that have to go in here, like where the specialists are and where can you get an ultrasound and where does the urine get done and how far do people have to drive, like it's hard to, I would imagine that it would be hard to sort of do a sort of one size fits all. Like I think there's going to be contextual solutions as we are used to for like all of these other things, like RSV in the north is not the same as RSV in downtown Toronto. And
Okay, I think in the interest of time, maybe I'll just sort of finish up by just reminding everybody that this webinar is being recorded and it will be available after our session today, once we get it posted on the CFID website, so the Canadian Foundation for Infectious Diseases website. And I don't know, and it'll also be on CMV Canada as well. So more to come. I know there were a couple of questions in the chat, and we can maybe get to them at the very end if there's some time then. Thank you.
Okay, great. So we have a 15-minute-ish break, bathroom/nutrition, coffee break, I should say. And then we'll be coming back to Dr. Pernica as our next speaker.
Alana Webster is next.
And my mistake. She's going first. Sorry. Alana Webster is going to be our next speaker. Thanks. All right. So as people are setting down from the break, we're fortunate now we're going to get into a bit more of the nitty-gritty of two of our colleagues who've been working in the trenches, so to speak. So I'm very fortunate to have our first speaker from, and I used to actually work in this region, Hamilton, where there's it's actually a fairly large catchment in province of Ontario, and where we're going to learn about some of their experiences and in the first province to implement universal screening. So we'll start with Alana Webster, who's going to be joining us online.
Perfect. Thanks so much. Can you hear me?
Yes, we can. Thanks.
Excellent. Thank you so much. Any chance, Des, do you know? Perfect. Okay. And I just wasn't sure if remotely how to change slides. Okay, great. Thanks so much. Yeah. Thanks so much for allowing us to have the time today to speak. I do not have any disclosures to share. In terms of objectives, so I'll sort of cover the two points here to review the clinical workflow for neonates who are screened positive for congenital CMV, and then we'll highlight the description of the role for the nurse practitioner in coordinating care for these babies. So I apologize, this was already sort of discussed, but I'll just review it very quickly again. So that newborn screening will reveal when there is a screen positive case to the corresponding regional nurse practitioner, who then discloses that result to the family and or healthcare providers as necessary. Those infants are referred to a community pediatrician for an initial evaluation that's including a physical exam, blood work, urine CMV, PCR, and head ultrasound. And finally, the infant is referred to an audiologist for an auditory brainstem evoked response, or ABR. And from those initial tests, babies will either be deemed symptomatic, in which case they'd be referred to pediatric ID for evaluation and consideration of valganciclovir therapy. They are referred to pediatric ophthalmology and will continue to be followed by a pediatrician and audiologist at the following intervals until about 5 years of life. The other category of children, do you mind just switching to the next slide? Sorry. Thanks, is those who are asymptomatic. So they are not referred to pediatric ID and they remain in the community. So again, followed by a pediatrician and audiologist at the following intervals until 5 years of life. And then the third category, albeit much smaller, but those whose urine comes back negative for CMV on PCR are also often deemed false positive screens. Occasionally, they will be referred to pediatric ID if further discussion in regards to test interpretation is needed for families, but otherwise would be discharged from the program. So in terms of what the nurse practitioner does in helping to coordinate care for these babies, so we perform the retrieval, which often will include a chart review as best as possible to determine the infant location, so whether they've been discharged home or may still be admitted to hospital. And to the best of our ability, their clinical status, whether or not they have had a hearing screen completed and what the results of that may be. We then typically will contact the family by telephone to disclose the result, or if admitted to hospital, may speak with the MRP and ask that they disclose the result to the family. And with that phone call, we try our best at providing as much education and information related to congenital CMV as possible, sort of based on what it seems like the parents may be able to digest at that time, but really trying to focus on the referral process, investigations that will be pursued, so that parents have an idea of what to expect. And then we do sort of become that main contact for families throughout this process, so as questions or concerns arise. And finally, we do also try to share the result with the primary care provider, just in case these families may go to them with questions or concerns related to CMV as well. And we also coordinate for all of the referrals. So referring to community pediatricians, as Dr. Dunn had mentioned, there is a roster that's provided by and sort of created by newborn screening of those who were willing to accept these referrals. Many of which as well, very fortunately, have been able to coordinate for imaging. So for example, head ultrasound imaging to be done on a fairly timely basis at their local center. And we also refer all infants to the infant hearing program, who coordinates for audiology referral. And typically we ask that these investigations be completed within about 1 to 2 weeks of that referral date, at least to the best of our ability. And then we are not only then the main contact for families, but also for primary care providers, pediatricians, and audiologists. And then the final piece of our role is sort of helping to determine the definitive diagnosis and disposition for these infants. So for those who are symptomatic, we ask that the provider who deems them symptomatic to contact us directly, and then that way we can coordinate for an urgent referral through the ID clinic. At that point too, we would also refer to ophthalmology and then ENT as well, if there is sensory neural hearing loss. For those that are asymptomatic, we also try to ensure that appropriate schedule follow-up has been arranged in the community. To the best of our ability, we try to ensure that all tests have been completed, appointments have been attended to, which sometimes can be a little bit challenging, but we do try to follow up with the family and the providers as needed and sort of be a liaison to help as best as we can to get families to these appointments. All of the results are sent back to us directly, so we can review them to ensure that any baby who is symptomatic has appropriately been referred to the ID clinic. And then finally, we also do support the pediatric ID specialists in clinic, which has been really nice, I think, in a way to be sort of a consistent person for families to be a part of the retrieval initially, all the way to potentially if valganciclovir is offered and started. And then in regards to some of the challenges that we occasionally face, some of which it's interesting to hear, I think have been echoed in Saskatchewan as well. So the first being obtaining and maintaining family contact can be difficult even just to disclose the results initially. So for those who may be living in precarious living situations, those who may not have an active telephone number, no family doctor listed, it can be quite challenging even just to reveal the screen positive result. In some cases, we have sent letters via registered mail as sort of a final last attempt of informing families that we've been trying to reach them. Which in the context of these investigations and appointments needing to happen in a fairly timely manner has been a bit challenging. I can think of a case in particular where I had sent a letter to a family whose mother then got back to me at around 3 months. Her infant was about 3 months of age. And at that point, she was quite interested in pursuing some of these investigations. So I think from a specifically to congenital CMV, and like I said, the timeliness of these investigations and sort of initiation to treatment for those who are symptomatic can be difficult when obtaining contact and maintaining contact is an issue. Again, was already mentioned, but a big piece, I think, of how we help in the care for some of these families is helping to support with the parental distress and anxiety that may be related to the experience as a whole. Oftentimes, we're calling families who have otherwise been told that their infant is perfectly well and healthy at home. And so it can be quite difficult to convey some of this information over the telephone. Explaining congenital CMV in and of itself can be quite complicated in terms of the testing and testing interpretation. If questions come up about treatment, it can be quite a complicated and lengthy discussion. In addition, for families who Google congenital CMV, I think it can be quite scary in that a lot of the information they're reading really doesn't pertain, and hopefully doesn't pertain, to their infant in the context of a screening program. So that also, too, I think provides, at least initially, quite a bit of anxiety and stress in relation to what it means specifically for their infant. We also tend to have quite a few discussions about maternal guilt. So again, echoing what's been said already about perhaps the lack of CMV-related information and education that's provided in pregnancy, to talk about whether or not there was something that the mother could or should have done differently while pregnant. So it's not uncommon to have several conversations over the phone leading up to visiting the pediatrician, sometimes afterwards, and especially for those who are found to be symptomatic and seen within the ID program, ID clinic, and especially, again, with the offering a recommendation of valganciclovir therapy. Just providing healthcare in general, I think, can be challenging in terms of accessing care for everybody. But again, in the context of this being quite timely, geographical barriers, so those who do live remotely, transportation barriers for sure comes up more frequently in the sense of not having access to a car, being able to attend visits on the particular days that they're offered and times that they're offered. We do try our best at making it as easy as we can for families. So in the case where a pediatrician may be able to see an infant on the same day as their head ultrasound, blood work, and urine collection in hospital, but it does make for quite a lengthy visit. In addition, the ABR testing with audiology usually takes a couple of hours where the infant needs to be asleep to complete that testing. So again, multiple lengthy visits can be challenging for those who have multiple children and commitments at that sort of precious time of having their new baby at home. We've recently had a case where a mother had moved with the infant a couple of hours away from her home address to live with the baby's father. She was initially very keen to undergo these investigations, but didn't attend any of the visits. So we rescheduled them several times and unfortunately continued not to attend them. And when she finally got back to me, she was able to sort of relay the social circumstances that she was in and the challenges she was facing. So we were able, thankfully, to be able to rebook these. But again, in the context of it needing to be quite timely, it can be very difficult to coordinate for access for all of these infants to receive care in a timely way. And the last piece that I think is sort of unique to congenital CMV in this context is a parental reluctance to believe the results. So again, oftentimes we are calling parents at home whose baby has otherwise been perfectly well and healthy until this phone call. So I do think sometimes there is a reluctance to believe the screening result and sort of what it means specifically for their child. And secondly, for those signs or symptoms that may not be as obvious to parents. So for example, if there is sensory neural hearing loss present or head ultrasound findings, it can be difficult for them to understand the severity of the infection, of how their child has been affected by it, and the rationale for different procedures that may be required or treatment. We had a fairly complicated case where a mother was quite adamant that her infant did not have any hearing loss, but was actually found to have profound bilateral hearing loss and was a candidate for cochlear implantation. And just the difficulty and sort of time that was spent in making sure that this mother understood how her child had been affected with, social work and child advocacy programs and multiple visits with multiple audiologists, second opinions from multiple ID specialists. It was just, I think, very, very difficult and challenging for her to truly accept the reality of the diagnosis and what it meant for her family. Which I think is, like I said, sort of unique to congenital CMV and just some of the complexities of sharing this information and being able to provide the best care that we can for these families through a screening program. And after that, I think I'll pass it back to Dr. Pernica in regards to symptomatology. Thanks so much, everybody.
Is this on? Awesome. So obviously she spoke first because she does the vast majority of the actual work that relates to congenital CMV screening in our region. Like unequivocally, we would not have been able to stand it up without her. And I am just going to be talking about the ones who drive to McMaster Children's to see us. Well, I should also say that the only reason I'm here today is because Jason Brophy was busy. So I am like a very poor substitute. So one of the good things that's about a meeting like this is that I feel like Alana has just described in detail how hard it is for sometimes for people to get to us. We live in Southern Ontario. Like we live in the most person-dense region of the entire country. So I think that some of this may apply to other centers as well. Jess has already talked about all of the signs and symptoms related to CMV, or congenital CMV. I'm not going to reiterate them here. I will just emphasize that there are some things that are very important to children and families. Cognitive delay, hearing impairment, vision problems, and things on this list that don't matter at all to children and their families, like thrombocytopenia that goes away by itself, right? Like this is a very wide spectrum of what we called symptomatic. Oh, another weird thing about the word symptomatic, if you look at the literature, is that it used to be that symptomatic didn't include isolated sensory neural hearing loss, which is sort of an issue because that's sort of a big deal to children and families. But anyway, we'll get there. So, and Jess has already talked about this, about how it can be very severe. And so if you look at studies where children were referred, so these are children whose doctors, nurses noticed something when they were born and referred them to a special clinic, in this particular cohort, 85% of them had abnormal CTs. That also speaks to how old this cohort is, right? Because we don't do that anymore. 43% had intellectual disability. A fifth had a significant vision problem, even though more than half had something seen on eye exam, and 3/4 had sensory neural hearing loss, right? And so this is a big deal for families. In this cohort, the major predictor was microcephaly. Now, when you think about it, people that you find by screening, right, are likely to be less severe than ones that get sent on purpose to a clinic, obviously. And this is another reference also that Jess had up before that just shows that the proportion of patients with significant anomalies is lower in a screened population. Now, in this group, a quarter had an IQ of less than 70, right? And so that is something that will affect a person's life. So it's still important, but the proportion is less. Now, I'm going to talk about the evidence a little bit. And the only reason I'm going to bore you with this is because I think it speaks directly to how conversations happen when we get these people in clinic. And again, it's going to sound like I am the people who did these trials. David Kimberlin, he's a genius. He's like a very nice genius, which is even better, right? He's smarter than me and better than me and did a better job than I could ever have done. The trials have problems, right? Because it is very hard to enroll newborn infants in randomized trials. And what that means is that the quality of the evidence that we have is lousy. And this has to be taken account when people are discussing what to do with families in the clinic. So this is the first randomized trial many decades ago, where they took 100 neonates that were at least 32 weeks of gestational age and randomized them to IV ganciclovir or nothing, right? So PICC lines for everybody, very big deal. The primary outcome was hearing. And oh yeah, so the IV GAN had, the people in the treatment arm had less hearing loss, but they lost 60% of the patients. So this is very iffy. They did another trial, right, using valganciclovir mostly. Again, this is a small randomized trial of less than 100 neonates that enrolled less than a month of life. And the thing is no longer working. All of them got IV GAN at the beginning, and then they got randomized to either 4.5 months of the oral or a thankfully blinded placebo. Because this is a small randomized trial, the groups were not balanced at baseline. And what they found was that there was no difference in the primary outcome. There was no difference in any crude analysis. There was no difference in best year analysis. If you look at the analysis adjusted for CNS disease at baseline, which I think is totally reasonable, and you do a total ear analysis, so you analyze every ear separately, there was statistical benefit from this 6 months of therapy for hearing preservation at 12 and 24 months. There was also some benefit seen in overall development at these timeframes, right? But this is not a slam dunk trial, right? They also had issues with retention. So even though geniuses did it and published it in the best medical journal that there is, right? We have to recognize the limitations of what we have. And that is what led to the formation of what I would say most people follow. This is a PDF from the Red Book that says that if you have significant congenital CMV disease, we would generally recommend 6 months of oral therapy, right? And there is a distinction made here. We would all worry, based on the previous evidence that we have, right? The children that we would worry most about are the ones that have a potential brain problem, who have small heads, who have significantly abnormal neuroimaging, who have an abnormal neurologic exam, whereas stuff like isolated blood work abnormalities that gets better, we would not routinely recommend therapy. Now, I said before that neither of these trials just took isolated sensory neural hearing loss, but we are most worried about sensory neural hearing loss. The other issue with sensory neural hearing loss is often you don't find it right at birth, right? As has already been discussed. And if you called Dr. Kimberlin, 2 years ago, and you said, "Oh, I have this kid with sensory neural hearing loss. Should I treat?" And he had a very reasonable answer. He would say, "We need trials to figure out what to do with them because they have not been enrolled." Spoiler alert. Again, even though there's a bunch of geniuses, the trials didn't work out great. Albert Park was doing a giant, multi-country, multi-center study enrolling kids older than a month of age with isolated sensory hearing loss. The trial had to stop. Kimberlin did this one. They enrolled 35 infants. So this is the size of like a pilot trial, right? Age that less or who were at least a month of age, and they randomized them to Valgan or placebo for 6 weeks. The primary outcome was hearing, and they found no difference. There was a Dutch group that tried to do the same thing. They stopped trying to enroll because they couldn't. And so they just developed this prospective cohort where 25 received 6 weeks of Valgan, 12 got nothing. They also compared to historical controls. And if you looked at hearing in like this toddler period, it was better in the Valgan group, right? But this is, I guess what I would say, and what I do say to parents, is that our certainty about how big the benefit's going to be is not high. These two studies led to what is now the Red Book recommendation for 6 weeks of therapy for neonates with isolated sensory neural hearing loss. And ideally, they start within 13 weeks because that's what the Dutch people did. Now, people have done different things, right? Like I have this slide up here just to show you, there was this Israeli cohort, this was published 6 years ago, where they just gave everybody a year, of Valgan at different doses, and they had amazing results, like more than 2/3 improved, and most of those improved ones came back to normal. But this is just a cohort study. And so it's hard to know what the impact of treatment is going to be. At the end of the day, Alana must be so bored to sit in clinic with me all the time, because I natter on about the values and preferences of family constantly. What I would say, these are not large randomized trials. The trials have problems. What I do, and I hate making strong recommendations when the quality of evidence is not high, but what I would say is that if there is evidence of CNS disease, I try to get families to treat. And as Elena said, right, this stuff differs. There's a bunch of families who don't want to give their brand new baby medicine. I think the question of whether or not there's going to be significant benefit for milder disease is in question. I think for sensory neural hearing loss, because that is such a big deal, and there is now a recommendation, I generally recommend, because I think the potential benefit may outweigh potential harms, right? But there is a range of different caregivers who have their own ideas about what they are willing to accept. And I think we have to take that into account. I've been going on about CNS disease and how I think it's important. Obviously, if you have a big defect, or if there is a important thing that neuroimaging finds, right, it would affect how the strength of our recommendation to go with valganciclovir. Now, in Ontario, we can get brain ultrasounds done in the community, which is really important to minimize undue anxiety among families that you're calling on the phone that you've never seen to tell them that there's something the matter with their baby. You can only get an MRI at children's hospitals. And sometimes for MRIs, depending on how big the problem is, you need to sedate them and give them enhancement and blah, blah. What the literature would show is that all brain ultrasounds and brain MRIs generally concur in terms of finding important things that relate to congenital CMV, but sometimes there are differences, right? So one of these cohorts is a Canadian one. One of them is an American one, and there are examples from Ontario where the MR gave an answer that would change our overall plan. And so that's why, as Jess already talked about, we are now offering non-sedated MRs. We're trying to walk the line again between maximizing harm. To sedate a baby, if we get a lot of ultrasounds, just to throw this in context, right? We get a lot of babies with ultrasounds with, like a cyst, which is entirely non-specific for CMV, which is not that unusual of a finding on a brand new baby, which may mean nothing at all. There's a lot of lenticular striate vasculopathy. I will defer to the neonatologist to give you like a good example of what that is, but suffice it to say that it is also non-specific, right? And to sedate and give all these babies gag would probably be more harm than good. So we are trying to get these done non-sedated, non-contrast scans. And our experience has been mostly positive, but this involves like an inordinate amount of arrangements, with radiology beyond what we would have had to do anyway. I would say that most of the babies that get referred to clinic do not have severe disease. And so the Ontario recommendations, the guidelines that we follow generally are similar to what is seen in the Red Book. And I have long conversations about what parents want to do. In terms of therapy, we commonly run into neutropenia all the time. Right. And so this is something that we warn people about. One of the harms of therapy, right, is that their brand new baby has to be bled every week. It doesn't have to be. We would recommend doing blood work every week for 8 weeks, and then every 2 weeks after that if it stays good, and then every month after that if it stays good. And if it doesn't stay good, you often are doing more of it again. So this is a big deal. And neutropenia is real, and we often have to stop and adjust. The transaminitis is not such of a big deal. Generally, that tends to go away in and of itself. And I put this little bullet for people who are trying to implement things. There are still weird areas in our region where valganciclovir is in the doctor books as being a chemotherapeutic agent. And so we have had public health saying, oh, you have to have gloves to throw away the diapers, and just be aware that different regions within your province may have different attitudes to this thing that is now very common. Am I over? Am I on time? That's it. That's what I got.
Well, thanks very much, Des and Alana. So I think we'll take a time here for some questions. I don't know if anybody has questions, or if we can go perhaps to the webinar, see if there are any of the questions from before or new questions from online.
Maybe I'll bring up one from previously. The others maybe I'll save to the end for the panel discussion.
Okay.
But this one I think is kind of relevant to where we are in our discussion to date. The question is, in the current climate of trying to break down interprovincial barriers, and I think we've had examples now across at least three provinces in Canada, would it be worth having a national congenital CMV strategy and advocacy, like through AMI or maybe CMV Canada, or maybe some other national statement or guideline? And I think, Des, you kind of spoke to, like, how do we get there if some are following the Red Book and some aren't, or, everybody has a slightly different interpretation. So maybe that's a good point of discussion to sort of talk about how do we get to sort of more consensus guidelines for people to follow, so there's more consistent practice across the country.
Was this pointed at me?
No, it could be for anybody.
I mean, I think that the treatment bit is the easiest bit, right? Because the evidence is there. I don't know for sure. Like, actually, Jess would know better than me what the attitudes of like pediatric ID physicians are across the country with respect to treatment. I bet you there's not that much variability, although I'm happy to be corrected on that point. To me, from my and again, I know much less than these people. I think that the challenges with the screening program are mostly operation, like how to organize that whole structure, and less about what happens in the pediatric ID clinic. I think the pediatric ID clinic is the easiest part of the entire thing, but I'm happy to be corrected if I'm misrepresenting.
I think you're right, Des. I think the operational standpoint for sure is where the kind of the hurdles are. And I don't know if that's easy to do from a national standpoint, just because each provincial sector has so many, like lab operations are different, health authorities are very different, like Kayla pointed out. So I'm not sure the consensus there would be very easy. I think we saw that during the pandemic because we couldn't really come with a consensus to even have infection control policies to be the same. So I probably think that that would be a work in progress. In terms of treatment options, I know we've had multiple conversations amongst Peds ID folks, even at CMV Canada meetings, and I think I would agree we're probably around this similar consensus. Like if it's very severe, you treat. If there's hearing loss, you treat. If it's asymptomatic, you kind of have that family discussion, whether they want to treat or not. And I think that most of us would be kind of on the same line. But yeah, I agree. I think it's the operational standpoint is difficult to centralize.
Thank you. Any questions in the room?
Can I just top on to that though? Is that I think one thing there is a Canadian consensus statement that was in the Pediatrics and Child Health kind of sort of spearheaded by Soren Gant, formerly of Vancouver, now of Saint-Justine in Montreal, along with Ari Bittman, Wendy Beaudry, and Fatima Kakar. So I think there was a statement there. The CPS also has, the Canadian Pediatric Society also has a statement authored by Michelle Barton Forbes, and I think has recently been updated as well to reflect the new guidelines and of the recommendations from the Red Book. I think what's tricky, as everyone said, on the treatment, so I fully agree with the operational thing. I think there's the clear indications to treat and not to treat. I think it's that middle ground and really trying to understand there's some things we do and some things we don't know about which children may go on to develop more challenges later on. And then is there anything that can be done in this interim? And so I think as we are more investigations and more findings and everything else that as we're starting to screening, we're at first finding more questions that need to be answered. And I think it's just about starting to kind of go through that. And I think it'll be a while before we get this all sorted out. But I think it's a little bit of that middle ground. You just have to do the best you can from now.
Thank you. Any other questions in the room? Oh, here we go.
Thanks so much for all of the talks today. It's super helpful, really informative. I did want to ask a question. I'm from BC and we're kind of in talks about how we implement congenital CMV screening and yes, it was super helpful to get that literature review as well and that update about the 13 weeks too. And I was looking recently at the CPS guidelines and for the more severe infections, they say treat earlier, but up to 13 weeks. And knowing that there's that time crunch in the existing screening programs of trying to get things done in that first month, do you think there will be any changes to the existing structure of the programs with that little bit more permissive statement, knowing that the evidence is not so robust to support that 13-week cutoff?
Wanted to meet you.
No, I just feel like I'm talking too much. Go ahead.
You're the one who knows the thing. So I would still say, and I'm happy to be corrected, that it is nice. Like, I think it is worth us trying to initiate therapy as soon as possible, honestly. I think what had happened before is that we would, consider where there was benefit on a case-by-case basis. Again, if there were severe findings for neonates who came later, I think this 13 weeks comes from these other studies that just happen to use that. And so I think it's useful. I think to have a liberalized guideline is useful in our ability to acquire therapy. Like, I don't know what happens in BC, but like to get Valgan paid for in Ontario often requires, approval through a government program, which looks at what the literature says in times of when you can start. Do you know what I mean? And this makes it much easier for us to get Valgan paid for the people who don't approve it. So I think in that way, it's useful to have this. I would still try to start as early as possible. It's really hard to know. The studies are so small. Sorry, was that an answer to your question?
I agree. It's easier to it makes the Valgan approval process for if you have to go through SAP easier. And I think most are of the same mind as Des, and I know I am. I don't, is that as much as we know now, probably it gives breathing room, but it's probably the benefit is probably to get something going early. Yeah.
Yes.
Uh,
$300 a bottle. So we're told.
so, and
in
the bottle
Alberta.
lasts, I'm looking at my pharmacist. There we go. Yeah.
At the early stages of treatment, when they're smaller, and it's because it's weight-based dosing, the bottle can last the full 7 weeks of the expiry. But as they grow, of course, that may not be the case, and they have to get more bottles filled. So, but it's about $300-ish per bottle. And coverage varies, of course, based on drug plans. Thanks.
I have noticed clinically, if I start them, like there is some patients that sometimes around 4 to 6 weeks, we just because we didn't get them in, but they have severe disease and I want to start them. Do notice that the neutropenia side effect is less common because maybe there's that physiological nadir that happens in that switch. And so I don't know if that's some benefit, and maybe that will help guide us for the future to see. But I know I've had multiple discussions with Ari Bittinen too in regards to should I treat this baby now that we're kind of past that? And he's always kind of said, yeah, like I think treatment, if it's warranted, just do it. So maybe there'll be something along those lines.
We have one more question on the floor.
Hi, I'm Leonora Hinson. I'm the neonatologist in the room. So I have a couple of observations and a question. What do you think about having a navigator? It sounds like that's to a large extent what Alana is doing. Like in each province, that would be something with the lack of family doctors and so forth, to actually have a navigator as part of programs, as a question. And then what about any Canadian cost effectiveness studies? I mean, I think that they are between targeted versus universal. There's shown to be cost effectiveness, but in our context, just to convince, governments and so forth to fund this.
1,000% yes to your first question. That one's easy.
Yeah. I mean, the thing about Alana as well, and I only know what I know from my own anecdotal experience, is that she also has like the medical, you know what I mean? So I think having a nurse practitioner in that role is really important. It's a whole bunch of organizing, but there's a whole bunch of medical questions, and so I don't know what I think we have other patient navigators at our hospital that do not have that medical training.
Yeah, sorry, and I was thinking having a bunch of Alanas or Leahs or Leannes or Mahailas, or lots of L's, would be, I think having that point person in that role is actually more what I was saying yes to, because again, they really are the ones that have both the interpersonal connection and then sort of some of the background from the medical side. And because they are housed within the ID clinic, there's easy connection there for sort of subtle stuff to talk to Des or Michelle or Ari or Jason or whatnot for some of those questions. And then there has been some cost effectiveness work that has been done. And again, Soren Gant had a really nice paper about showing that it is cost effective. I think now that there is some real world actual experience done with universal screening, that needs to be looked at. And I know that's part of it referred to a saliva project that's going on in Ontario, kind of in parallel. And part of that is looking at cost effectiveness as well. To see, how that is or isn't making, or seeing what the impact of saliva screening and then comparing it to the dry blood spot screening. But it's a big question that has to be answered. yeah, so and I think my view is it's a pretty big upfront cost, but I think the savings and whatnot that you're doing down the road will trade off. I just need the numbers to show that a few more hours in the day. I don't know.
Yeah, I can just add, I was buried in the middle of that paper as a co-author, but that was actually done without looking at the impact of antiviral therapies, primarily looking at the impact of early hearing interventions, because as you saw from Jess's data earlier on, those actually can have significant impacts looking at long-term outcomes, and maybe even more important than the antiviral piece that we tend to, as IDE folks, focus on quite a bit. All right, unless there's no other questions, we're going to have some, hopefully, time for discussion. I'm going to be just doing a bit of background on the next topic, which is focusing on the diagnostic piece, because as you probably heard, there's still a number of challenges and questions related to congenital CMV diagnostics. And so, the question is, and what we're going to want to discuss as a panel is, can we do potentially better in terms of diagnosing congenital CMV? And you already heard about a bunch of these. And the nice thing about this topic and what I dwell in is the pre-analytical piece, which is usually the most boring part of lab diagnostics. So this is the part before the actual test that's done, but it's the sample type, quality, those kinds of things. And in this space, in congenital CMV diagnosis, it's actually, I'd say, perhaps one of the most important aspects of the diagnosis. And then you do have to be aware of the clinical context. So if you're trying to use a test for clinical testing, that's different than universal screening. And the characteristics of that test may vary depending on that context. So what your pretest probability is, for example. And so the big two types that we tend to use on the clinical side are, and this is at BC Children, but also now in multiple jurisdictions and are in the guidelines, are either a urine sample or an oral swab. So that's on the clinical side. There tends to be very high quantities of CMV DNA in urine samples in congenitally infected babies. And similarly in saliva, CMV is actually produced in the saliva glands. And so there's tends to be a relatively high concentration in both of those samples. The issue is, as you've already heard, they have to be collected before 3 weeks. And even there's some data that between the second and third week, you can sometimes get postnatally infected children secreting CMV at that window as well. So that's one of the challenges, is that you need to get this sample early. We did some evaluation looking at different sample types, and particularly trying to look at how we could optimize oral saliva swabs. When we were trying to implement initially a more targeted program, one of the challenges we had encountered and people had told us about is trying to get a urine sample, as you heard. For example, newborns often don't urinate for the first 24 hours. So if you're trying to get a sample before a baby goes home from the hospital, nowadays babies are often discharged even before 24 hours of age. So we were wanting to find ways from the lab point of view that we could facilitate testing. So we looked at a bunch of different types of swabs, different ways to get the sample from the swab to the test. So you could either put it on filter paper, so take the swab and then rub it onto filter paper that could be tested, or drying it, or putting it into media. We found actually it going into the liquid media was usually the best yield of getting sample. The filter paper also looked quite good. These are just showing you CT values, so the relative amount of virus, or they're showing you the log viral load when we tested these different sample types. And there was actually quite stable in those samples. So filter paper was quite stable almost out to 14 days. There's a bit of drop off at 14 days. But the other sample types, they were generally quite stable out to 14 days. We also had 4 babies in this study that had congenital CMV, and we looked at 2 different media, so the liquid that the sample is held in, and those are also quite stable out for 7 days out at room temperature. which is important if you're trying to look at this provincial program, you know, where it's going to take time to get those samples to the lab. We also looked at, there's the first commercial assay for congenital CMV. We looked at that and evaluated that, and that was with a saliva sample. These are instructions. One of the things, as you'd heard before with dry blood spots, similar with oral saliva samples, is you have to confirm with the urine. There is the possibility, and it's not that uncommon, that breast milk will have CMV DNA, if not virus, present. And so if a child's breastfeeding, you may get a false positive. So we always still need to confirm, and that's one of the issues with the saliva sample. It tends, though, to be quite sensitive. And that's also why we have the instruction of needing to wait an hour after breastfeeding before collecting that saliva swab. Urine samples, PD bag collections will help facilitate that. But again, there are challenges with that. Babies, especially in the first 24 hours of life, are not producing a lot of pee. I could only imagine getting 20 mLs of pee in that first 24 hours would be a bit of a challenge. And then these PD bags leak. Anyone who's had to try to use them, they do not hold pee that well unless you're quite skilled at applying the bag. There was one study done with colleagues at the US CDC where they looked at urine in filter paper, and that was promising, and that's people are looking at that as another way, but still that would require the urine sample. But this one option might be to place the filter paper in the diaper to catch the urine. And then obviously dry blood spot is what's been implemented for universal screening, which we'll talk about next, but we also use it on the clinical side. It is traditionally been the least or the less sensitive sample type. So we'll tend to offer it. We've been offering it for near 20 years now at Children's. That's if no other sample is available and they're over 3 weeks of age. Unfortunately, we still say it cannot be used to rule out congenital CMV. And that's mainly because you're talking about relatively low volumes. There's just one study showing how small the volumes were, depending on how many punches you take. But you're talking about 0.6 to 8, or sorry, 1.6 to 8.7 microliters of actual blood, depending if you take 1 or 2 punches. And then blood can sometimes have lower amounts of virus than urine or saliva. There was a systematic review of the sensitivity of dry blood spot. Overall, the estimate was at about 84% sensitivity. The issue is there's quite a bit of variability. There are some settings where it's quite high and others where it was low. And it seems like, again, some of these pre-analytical steps, like how many punches you take, how your extraction is, that will influence. At our center, we did do, as part of the evaluation of our dry blood spot, we had 16 babies that were diagnosed with congenital CMV, a third of which were asymptomatic. And we do we test them in quadruplicate, and then we punch the entire spot. So that's about 10 punches. So it's a very labor-intensive process, the manual extraction. And we were able to, in this setting, you can see most of the times it was detected. We had one of those 16 patients where only 1 out of 4 of those tests were positive. So that would be called an indeterminate result. This is obviously not possible to implement this type of a protocol on a mass scale where you're running hundreds of thousands of samples, for example, in Ontario and across Canada. So it's very labor intensive. So in terms of universal screening, there's different criteria compared to testing a child where you believe they have signs of symptomatic congenital CMV. So it should be a suitable test, and it should be acceptable to the population as one of these held criteria for a newborn screening or any screening program. And so, I mean, as has been said, we do have now the majority of children are or will soon hopefully have universal programs in the center of the country. Now all of the 4 provinces there have either implemented or will, and Nunavut has also committed. And there's now been several jurisdictions in the US who've implemented universal screening. Obviously, are learning, and this is one of the exercises here, was to learn about the experiences and some of the challenges with respect to diagnosis. One of the things to be aware is this is a huge number of tests in terms of doing a PCR test. Influenza testing in the US, it's about 800,000 are done annually at all the labs. Really only sexually transmitted infections would be the only one where there's more molecular testing, but in the US, you'd be looking at about 3.6 million molecular tests. So that's a big volume of tests, and it's quite an expensive enterprise when you're talking about cost utility. This I took from just to, I guess, perhaps seat the discussion. This was from a recent review published in Journal of Clinical Microbiology, talking about universal screening for CMV and what were the kind of benefits. One of the things I might put an asterisk next is they had the specificity for dry blood spot is 3+. I think from programs that have implemented this, and that's been our experience as well, you can have false positives. A lot of this data is from research studies where you had research coordinators collecting dry blood spots. Dry blood spots are not collected as a microbiologic sample, so they tend to not be handled like we do a lot of microbiologic samples. So there can be issues with respect to specificity, and that's what I think we've heard about today. But there are pluses and minuses of each of these, and it's so far the programs that have implemented in Canada have used dry blood spot, but I know, as Jess had mentioned, in Ontario, they are looking at oral saliva samples, and that's something we still need to understand a bit better. There is some data about false positives, oral saliva, as Jess had mentioned earlier. Minnesota had a study where they did find 8 out of the 60 CMV positive saliva samples were false positive. So those tended to be very weak positives, and there's a possibility to count those as indeterminates, and they may allow for those to not be counted as true positives or reported out as positive. Then on the analytical, this is the only slide I have on the analytical side. There are some issues to consider. There have been multiple targets that have been used in the different assays. Those are different genes of the CMV virus. There can be variations. So there's reports in the UL55 there have been false positive or false negatives or dropouts due to that gene having some differences, and then the test doesn't work. And if you're also wanting to get a sense of the quality of your saliva sample, including a human gene, so you know that there's actually some human DNA in that sample, might be important as a sample quality control. So with that, I will now give us some time for a discussion. I see we have about 7 minutes. I don't know if you want to start, Larissa, with the online questions.
So maybe I'll start in the room first. Any questions? Thank you, David, for that. Any questions from the room to start? Yeah. Okay. I have some questions from earlier today that I think we can get to. Maybe I'll start though, David, since I'm one of the microbiologists in the room as well, to ask a little bit about the testing that you're doing. So what testing are you doing right now in BC? So based on all the studies that you've done, what did you actually land on in implementing in your lab?
So we offer basically for congenital CMV, there's 2 sample types. So we'll usually and always offer oral saliva sample using a flock swab and UTM. And that was the one where we looked at the stability over 7 days at room temperature, because that's one of the issues. We did try to centralize the testing so that communication can happen and all those kind of downstream pieces could happen. So in the province right now, we're the only ones offering that test. So that's about 70% of all of our neonatal CMV testing is oral saliva samples. And then we'll do urines as well. So those will be for confirmatory, or if it's possible to collect that, because urines, the nice thing is you don't need to confirm once you have that result. It's generally felt to be quite specific. And then we do dry blood spot, but those are batched. As has been described around that specificity issue, the issue is if you're testing a really strong sample and then test another one, the filter paper, just the material can sometimes cause a bit of a plume. So we tend to do the actual processing on different days and then testing on one day, but it's quite a involved manual process. So we just from a labor point of view, we have to kind of batch those. So we do those monthly unless there's an urgent request.
A bit of a follow-up question to the testing piece. Is there a sense of what size of filter paper would be equivalent in sensitivity to the 20 milliliters of urine that was said to be recommended in one of the earlier talks?
So I don't know if somebody wants to speak to that. So we basically punched everything we could. So the newborn screening program will give us one spot, and we'll do the 10 3-millimeter punches just to maximize sensitivity. I haven't seen myself, there may be the data, but I haven't seen data where people have looked at punching different numbers of punches or different volumes of dry blood spot and then comparing that to gold standard yet. So I don't know. We do eventually want to look at a larger cohort than that 16 and give us a better sense of how sensitive that is over time. But I don't know anyone unless anyone else knows about data.
So just done a little bit of work. So I don't know what the equivalent volume to the 20 mils of urine is, but I think we do know that sometimes on the blood spots, sometimes there's areas just where the CMV ends up being more concentrated than the others. And so it's what I've heard, not being a lab person, so I take that with a huge chunk of salt, but in Ontario, it's routinely 2 punches that are done. I think you know, when there are cases of having an infant who doesn't get picked up on the screen, but we find out about it because, you know, one of the ID docs has identified a child otherwise, sometimes we will go back and ask for that sort of extra testing to be done on. We've got 2 levels. So there's a screening of the first assay, which is multiplexed with the SCID and with the SMA and everything. And then if that brings off positive, then it's done in a larger volume well on the confirmatory assay. And so all the, what we call infants at risk, so infants who are sort of asked for retrospective testing to be done, gets done on the larger volume confirmatory assay for one. And I've heard, but I can't speak to the details of this, for sure from Minnesota, and I think our lab as well, if you do punch more, then, you know, you are in theory increasing your yield of potentially getting more blood in there to get more. I don't know what the equivalent sample is.
So I think to your point, David, like the pre-analytical piece, which includes not just the collection.
Yeah.
Okay, you can hear me. The pre-analytical piece is not just the collection, but even like the first steps of processing in the lab to understand how to impact sensitivity and specificity of the test. I think the other piece, point of clarification was, what about urine collected on filter paper? So how much of filter paper do you need relative, like how do you make that conversion from 20 milliliters of urine to urine on filter paper?
Yeah, so I can't speak to that. I believe Quebec has some experience with that, but unfortunately we don't have anybody from Quebec here, I don't believe. But yeah, I can't speak to what the volume is. I mean, urine, that was one of the things I was interested in hearing about, because urine is always felt to be your highest yield sample because there tends to be a lot of virus and congenitally infected children. So we haven't usually required a large volume for when we're testing it. Our extractor takes 350 microliters, and that's what we extract. We don't concentrate it, but it sounds like in Saskatchewan, they are, the lab there is concentrating that.
Yeah, from my knowledge, also not being a lab person, unfortunately, don't know what the kind of background of that is, but I guess I mean, we are still picking it up at the smaller volumes for sure, but if it's a true, like, if it's a false negative, then we're asking for more volume, and we picked it up in those cases. So I don't know if we truly know the cutoff amount either, because it might vary, think it also, I mean, we've looked at this, and I think the Quebec group, like Fatima Kacker and them, they've looked at this now recently, is to see kind of does viral load, because we never really talked about this in the past, with CMV and viral loads and checking them. And so me and her were having this discussion because, oftentimes we don't check that. But does it relate more with severity? Are those babies shedding more in their urine? And maybe we'll pick it up and it's more, the assay might pick it up better because it's a higher viral load. And so some of the, hopefully in the future now, we'll have some more studies where we can actually look at how the viral loads are being interpreted in this context. And maybe that'll make testing easier too.
This is related but not the same. I think this is all great talking about the sensitivity of the different assays. One thing I will say at a practical level for anybody, any jurisdiction that puts in screening, we had to talk about it constantly to let people know we were screening. And then what we found is that when people knew that we were screening, they sometimes would not test if there was a suggestion of, like if they thought a neonate possibly had symptomatic congenital CMV, they wouldn't test because they would think that it was being screened, whereas we would not recommend that. Like, so as everyone has said here so far, that you really need a urine to maximize sensitivity, and that is sort of an implementation thing that I would say is relevant.
I'm just going to go back to some earlier questions. So I think, Rupina, this one is directed at you. In Saskatchewan, how many infants have you found to be symptomatic versus asymptomatic with sensorineural hearing loss?
It's a really good question. I wish I had my, we did an analysis and I didn't focus on this for the talk, but trying to remember the numbers at this time. So, you know what? Is it okay if I look at my email and I can give an actual number? Because that might be better. Instead of giving you guys, because we've actually looked at this analysis, but I didn't do it for the talk. So you want to move on to the next question?
Yeah,
and
sure.
then
I'll
go
move,
back to
I'll
it?
move to the next. And anything in the room? Well, here we go.
Thank you for everyone's discussions today. I had a clarification question from Jess's talk about the consent process, and I could have just missed it. But I was just curious about the consent process. You said that was like kind of a little bit of a barrier in the process, and I'm just wondering like where that consent process came from, what is it for, and like if we're going to implement something in BC, is that something that we need to incorporate as well?
Yeah, so part of that is, again, the dry blood spot is kind of an opt-out. And so in Ontario, and it was previously run, things have changed now because Newborn Screening Ontario has sort of enveloped the infant hearing program, but some principles still stand. And so with the Ministry of Health and the newborn dry blood spot, it was like an opt-out. Every baby got it. Parents could decide they don't want it. With the Ministry of Social Services, Community Services, it has MCCSS in Ontario. That's where the infant hearing program used to be housed, and sort of the overseeing advisory board there felt understandably quite strongly that hearing screening needed to be a consented process, and part of that is out of sort of maintaining respect for the deaf community, deaf capital D, where some parents who are deaf may not want necessarily to have their child screened for hearing loss because they plan to raise them. I think I'm doing the proper understandings, but I'm happy to be corrected. Just with sign language and ASL and sort of in terms of a non-speaking household. So I think to kind of maintain that, why would you then do screening for risk factors for hearing loss if you never wanted your child tested audiometrically for hearing loss? So to kind of maintain those sort of principles and respect for those groups, which as we saw are definitely not the majority, but still important, that was the decision was made. And then in the beginning of the pandemic, the government decided that IHP was a non-essential service. And so screening wasn't happening, which is why we were kind of missing the opportunity to then do the consent, because that was done by either the screeners or whoever was booking the screen at the time. And so that's kind of where the history came, and it was felt very important to maintain that because again, this wasn't being done as a CMV screen, it's being done as a risk factor screening for hearing. Does that kind of make sense? Or settle?
Okay, this one, oh, sorry, Peanut,
Yeah,
you
I
have an
can,
answer.
yeah. Sorry, was it to ask if there was how many symptomatic infants that had sensorineural hearing loss?
Yep, symptomatic versus asymptomatic.
Yeah, so of the symptomatic, actually, so the data that we analyzed was actually only until February. So then, so I don't have like March and April, the numbers that we saw were different. Until February, we actually had 46 confirmed positive, and then of those, sorry, those are the symptomatic ones. And then of those, 0 had actual sensorineural hearing loss, but 21%, so I don't know the exact number that equates to, but 21% of them had some abnormal head ultrasound findings. That was our most common abnormality. Second being hyperbilirubinemia. So conjugated hyperbilirubinemia that was persistent. I can speak from a clinical standpoint now, though, and I was just talking to Jess because I was like, wow, in the last 2 months, I've had 3 infants now with profound hearing loss. And bilateral, and then now are on treatment. And so that was from February till April.
Okay, so just going back to one of these, maybe we can wrap up with these kind of questions. You know, I had, maybe there are some pointers around what mechanisms you use to obtain funding for your programs. Did you put together applications to your ministries of health? We have big challenges in BC getting allied health support, which is needed for sustainability. So any pointers would be really much appreciated. And I think this kind of dovetails to the follow-up question, which I asked earlier, which kind of went down the path of treatment. But how do we also then advocate for guidelines around implementation of programs in the operational perspective as well? Anybody want to start?
Clearly everything. I think, you know, for, I wasn't involved in sort of going to the Ministry of Health in Ontario when that started. So I can't say, you know, what the secret to success on that front is. I think you really do need a champion within newborn screening, though. And to sort of say that this is worthwhile, it's for the betterment of child health. And I think you need someone who's going to remain strong, that it's not, that if you're going to do it, you have to do it in a way that will deliver, because it's not, I think, arguably harmful to just do screening and not have the follow-up for families. And that's a downside, and that's potentially actually more harmful than beneficial. So I think, yeah, I think having a champion within screening that knows how to have those discussions and do that, but every place is different, as Kayla mentioned earlier.
Yeah, I think similarly, unfortunately, I also wasn't part of the initial conversations, but the talks I've had, I know at our center, like I mentioned before, ENT audiology were a huge push because obviously the morbidity and mortality or the morbidity that's associated with sensorineural hearing loss and long-term delays and also like resources, et cetera, was brought up to the ministry. Definitely having all the stakeholders involved and then looking at the avenues, I think that's important. I think the best benefit or one of the things that I would recommend would be if somebody is trying to have those discussions with the ministry, probably reach out through us via email, and I could probably get those individuals that were involved initially in conversation with them because they might have more details as to kind of how really the work was in progress. So for us, I think it did take a few years for sure to have that, have those discussions and really make it a point. And I think the problem with CMV, and I think somebody brought this up too, is like, why have we never talked about this before? And it's not that we've never talked about it. It's we've talked about it a lot. Probably all of us have talked a lot about it, a lot, learned about it a lot because of our profession. But I think it's one of those things that just lacks a lot of evidence and consensus, and that's probably what creates that not mistrust. I don't want to like say that, but probably creates kind of the lack of urgency in it, because if a bunch of infectious disease physicians sitting in a room can't come up with, you know, a way of treatment or how to implement this in each province, I think other people might find that difficult to believe. But I think it's one of those things that eventually there will be hopefully more studies, and that would benefit, but it's such a sensitive area. So I'm not sure if, and maybe having more long-term follow-up, like for us, I think because we're such a new program and we don't have that 5, 10 years or 15 years of follow-up with these patients, we don't actually know some of the long-term benefits either, or the long-term consequences if they were missed in screening. So I think time will help with that.
At a very local, I know obviously much less, but at the Hamilton level, at the very beginning, we got half of a nurse practitioner. We had to find funding at the hospital level for the other half. So I think it's useful. Like there's obviously a centralized, like you have exactly as they said, you need somebody central who is advocating, but also the hospitals where this is going to be operationalized also need to be part of, you know, developing the network of people who are going to be running the program.
Great, and I know it's been really great discussion, but we're a bit over, and I just wanted to thank again our wonderful group of speakers and also our sponsors of this event, Altona and Roche, as well as CMV Canada and CFID. I didn't introduce Larissa, who's the president of CFID, and I want to give another round of applause for everyone that's participated. Thanks, everyone. I should maybe give a shout out. There is going to be another meeting adjacent to the Canadian Pediatric Society. So if people are going to be out in Quebec City in early June, there'll be another, and that's where we're going to be working to try to build some further consensus around this issue and not have these kinds of disparities across the country that we're seeing right now. But thanks again, everybody.